We're going to get started in just a minute. We do have a virtual option for this conference.
This giant building, and it's just
They're getting folks admitted into the room. We'll get started in just a second. All right, good morning, everyone. We'll go ahead and get started. Thank you for joining us this morning. To those that are online, we appreciate you joining us via the virtual option. I'm Will Keller, the chair of the North Carolina Administrators Association. Want to remind everyone of our next conference, which will be held in Wilmington, starting February 28th through March the 4th of 2022. February 28th through March the 4th. March 4th being the Friday, which we will repeat the medical director and OEMS update. As we change presenters this morning, we will have to pause just a minute to switch out. We are using two mics since we do have the virtual option. We've got a number of folks joining us, so please be patient with us as we switch out the audio. This time I'll turn it over to Regina Crawford for opening remarks and a short presentation.
Good morning, everyone. Everybody can hear me? Can you hear me in the back? Awesome. Most of you know me. For those of you who don't, I retired from OEMS in 2015, and I went to work with EMS Management and Consultants as their advocacy liaison. I also represent the association as their advocacy liaison. So I'm in Raleigh, DC, wherever I need to be, advocating on your behalf. And I really wanted Governor Cooper to be here this morning. We've worked on this for over a year. We were supposed to have a day where Governor Cooper and his staff were going to come and they wanted to interact with EMS. Well, that was not possible due to COVID, and all of you know how much we've been through in the last year and a half. I personally want to thank you for everything you've done, the sacrifice each of you make every day. In addition to your EMS role, you embrace COVID and you're on the front line from the beginning. So as an appreciation to you, Governor Cooper could not be here, but he wanted to send a video thanking each of you personally for your enduring commitment and dedication to EMS. Thank you for all you do. Hopefully this time next year, we can have our EMS Legislative Day, and maybe we'll have a face-to-face with Governor Cooper and have that opportunity to discuss some of the issues that are on the front line for EMS. Thank you.
Hi, everybody. Governor Roy Cooper here. It's great to be able to say hello and thank you. Whether it's a trip to the emergency room or a once-in-a-generation pandemic, North Carolinians know that we can rely on our EMS professionals to keep us safe. You are the first responders in a crisis, acting quickly in life-threatening situations to help people when they need it most. Your jobs are challenging under normal circumstances, and you've had to make tremendous sacrifices to treat COVID patients this past year. I know it hadn't been easy, but your hard work has saved countless lives. I'm grateful for your selfless service to the people of our state. North Carolina is a stronger and safer place for our families and communities because of you. I know we'll come out of this pandemic even stronger than before, and that wouldn't be possible without your service. Thanks for all you do, and keep up the great work.
Good morning, everybody. So for those of you I haven't met, my name is Tom Mitchell. I'm the chief, has been the chief of the Office of EMS since Regina retired. And I want to echo her thoughts in the fact that I want to thank you from the Office of EMS for what you've done over the past 18 months. I told somebody on Monday or Tuesday when we were coming down the elevator that this is probably the first thing in the past 18 months that has actually felt a little normal. And I think you all will agree with that, this conference and being able to be face-to-face, even though we are still in the midst of COVID, it actually felt normal. And felt good, and it felt like that we were getting back to whatever normal was. So I thank the administrators for still continuing to let's prod through this conference. And I know that it hasn't been easy for any EMS person to endure the past 18 months, but it has been a challenge, and we've made it through it, and hopefully we're coming out on the other side, even though we are seeing a little surge right now. So in today's world, I don't think you can have a meeting without talking something about COVID. So I didn't want to disappoint y'all and not mention COVID any time during this meeting, because you knew that it was coming. So I want to ask Kimberly Clement, if she will, to come up and just give us a little brief idea of the current maps and projections of where COVID currently stands. And then I'm going to try doing my part of the presentation from that point on, not to mention that word, and get you back to some sense of normalcy. So I'm going to let Kimberly kind of talk real quick about the graphs.
Good morning. I'm tired of saying COVID, so I will say, I hear Tom say he doesn't want to have to say it, but I'm definitely tired of saying it. So there is that. Hopefully many of you had a chance Monday to join the webinar. I will say I have updated these slides. These are correct as of the 5th. So we have added some new information. Some of it is positive. I will say on our leadership calls, we're constantly trying to find some positive somewhere in something. So we'll go with that. Okay, so it should be very familiar to those who looked at it previously. This really is looking at cases. So one of the things that we've started trying to do is some predictive analytics to say, when we start to see cases go up, how quickly do we then see EMS call volume go up or hospitalizations go up? So in these two slides, you can kind of see where we went from June to August, and June of 2020, to be clear, because we've done this for a long time. In the middle, of course, is that surge that we saw over the winter. I think the thing that has been most concerning to us over the last month is that the surge we are seeing right now is much faster. And this is true for the cases specifically. I'll try it. Well, so here's our statewide trends with the past 2 weeks. As you can see, our numbers are definitely going up. One of the reasons I put this in here was to show this is where we are today. So as of when we pulled the statewide trends for 2 weeks to go 1 day forward, you see how quickly these numbers are going up. And that is part of what is so concerning to us. The number that I personally pay the most attention to is the admissions in the last 24 hours. That number has gone up dramatically. We were down just in the early July timeframe to maybe 30 to 35 on average. That means a lot of hospitals never saw a COVID patient that day, right? And so we were in a really good place at that point. Now, 241 patients were admitted in the last 24 hours. The likelihood is almost every hospital in this state saw somebody who either they thought could be or was a COVID patient. The other number we pay close attention to is our capacity down in the bottom left. Yes. ICU in particular is difficult. 85% is the highest capacity we've reached throughout this entire time. And I want to make sure I am very clear that is all ICU capacity. So NICU, PICU, the list goes on. We know that we can't put an adult with COVID in a NICU unit. So while it may show that we have some capacity, when we start looking at the numbers more closely, we really don't have a lot of capacity left, especially when it comes to the ICU. That's where the backup and the emergency departments are coming from and those types of things. So this is where I'm going to find a little positive, right? Focus on the little bit of the positive. You see the straight up, that was the concern. That's when we all kind of started going, uh-oh, we have a very real problem. But you will notice over the last couple days, our moving average is starting to come right back down in somewhat of a similar pace. Too soon to say that that's what's going to continue. But when you look at how the Delta variant acted in England and in some of the other locations, they saw a quick rise and a quick drop. So we are hopeful that the quick rise will be followed by a quick drop. However, hope is not a plan of action. So we are trying right now to be as prepared as we can to make sure that if this turns around and goes the other direction, we're ready for it. Same is true when you look at our 7-day moving average for COVID admissions. Quick clarification. Hospitalizations is how many people are in the hospital every single day. Admissions is who got added in the last 24 hours. So that's kind of how we look at it differently. And we track demographics by admissions so that we know how many of different race, ethnicity, gender, et cetera, are being admitted to help us better target different groups and campaigns and such. This just shows sort of a normalized list based on coalition region. The CAPRAC region, which is in the triangle area, has had the fastest growth. And I think they would 1000% agree with that. They went from a day where they actually had absolutely nobody in their hospital and celebrated as they should, to very quickly it got back up to they are almost up at that top spot there. So these maps really quickly just show us cases per 100,000 residents. The reason we do this is just to make sure that people understand, obviously, certain places like Wake and Mecklenburg, because they have more population, their numbers are going to look different. So we normalize it to the 100,000 residents to give you an idea of sort of the density of where COVID cases are hitting. The Southeast right now is having a little bit of a hard time. This is from sort of that early to mid-July. When we move to mid-July to August 3rd, you can see the state has really gotten a lot worse, right? That's that steep jump up that we have seen. We did, man, I'm frozen again. Well, if it ever changes, you will see that the hospitalization rates are also following and making some of those changes as well.
Next slide.
Yes, please, if it will. There we go. Okay, so this shows you the hospitalizations, the admissions, the new admissions. So early July, very few. This is again normalized to the 100,000 population. And then coming up to, that's okay, you're good. What it'll get to is when you get up to where we are currently, you see a lot more of the state. Can we go back one slide if possible?
Technology, gotta love it or hate it.
All right, don't worry about it. We're good. We'll stick with this one for here. There we go. All right, I think it's letting me do it now. So where we come up to in this kind of most recent one, week of 7/27, so that's where the week started. So it kind of brings you to where we are currently. You'll see a lot more new admissions across the state. But again, when we normalize it for the 100,000 population, it helps you see the areas that are really getting hit the hardest. Remember, it's kind of weird in the hospital and EMS world, right? So the larger counties have a lot more resources, but they run a lot more calls and they're a lot busier. So it's kind of a weird way to look at it. But the reason we do this is just to help us really see what areas kind of need maybe some of the most support at that time. Uh-oh. I'm done touching this. So we're just going to say next slide whenever you're ready. What we're going to go to next maybe is we have run a forecast. So basically I want to be very clear. It's a forecast, not a model. A model builds in a lot of things like like anticipated vaccination rates or new variants or weather, things like that, holidays, right? We don't do that. We do have models. We pay very smart people to do models. That brings in a lot more factors than we do. We take the forecast and it is literally, if we just keep going at this pace and nothing changes, this is where we're headed. Okay. So this is kind of the beginning of August, and you can see the projected COVID hospitalizations. So that's the number of people sitting in our hospitals continues to increase. Next slide, please. There we go. So here, this gives you the numbers of sort of where we could potentially go if we keep going at this rate. So the biggest concern, obviously, 5,000 total COVID hospitalizations is a lot, right? We've seen this over the winter time. We know that there are a lot of things that we can do. There are a lot of triggers in the healthcare system that we can pull, but that is a lot of people in a very, very, very short period of time. The ICU COVID patients, to be completely honest, is our bigger concern. We are growing at a faster pace with that than we did previously over the winter, and we do not have the capacity in the state to manage that. I don't say any of this to scare. It's really just, honestly, this is what the numbers are showing us, and this is what we are basing a lot of our decisions on and a lot of the triggers that we're pulling right now to try to make sure that we are prepared and ready. The monthly average, sort of our way of looking at it as, well, maybe it doesn't stay exact same trajectory, and we can average it out between what we saw last month or 2 months ago with what we saw with July. And if that's the case, we do expect to still see a really large jump, especially in our ICU adult patients, but it won't be as bad as if we continue on the same trajectory. Next slide, please. Okay, so we wanted a lot of graphs for the EMS data. I learned a couple things. One, I learned there's a lag in getting that data. I don't understand. You guys probably understand it a lot better than I do, but what I learned is that there was a lag in getting some of that data. So we could not provide the data up to date to make it work the way we wanted it to. David Ezel and I literally did hand math. He gave me numbers. I sat in an Excel spreadsheet. We played with the numbers, and that is where this came from, but we did not make any pretty graphs. So basically, when you look at 2019 to 2020, we saw normal growth or even some drop off because people stopped calling 911 for a period of time, right? But when we look right now, week to week, comparing 2021 to 2020 or to 2019, we are seeing an increase, a large increase, as I'm sure many of you are feeling right now, in the EMS call volume. The other thing that we looked at was when there are case increases or outbreaks in certain areas. So there was a county that had an outbreak that was pretty large. It has spread to a lot of the surrounding counties. It was determined to be the Delta variant, and they had a 26% increase in their 911 call volume within 3 days of that outbreak. That is a huge increase in that call volume. You guys know that? I mean, it's simple math. That's a lot of increased calls. The good news that we saw was that once those people all got into the hospital, the call volume came right back down to where it was before. But from an EMS perspective, we think it's really, really important. We are trying to proactively let you know when we see case rates increasing. We have built some dashboards that will say, hey, we just saw a 3% increase in this county, and we'll go do some digging. Why was there a 3% increase, right? Sometimes it's easy to say, oh, okay, it was an outbreak at a correctional facility, most likely not going to have that same impact. Or we'll look at it and say, this was a community cluster that's likely to spread. We need to let the hospital know. We need to let EMS know. So I want just for awareness, we are pushing that information through our healthcare coalitions to get that information out to you guys as quickly as we can so you can do with it what you can. Pray, cross your fingers. I know you don't have more staff. I know you don't have more trucks, but we do want to at least try to make you aware so you're not caught off guard. Next slide, please. All right, so I'm a big fan of quotes. So this has been the one that I have used throughout this entire event. Staying positive doesn't mean you have to be happy all the time. It means that even on hard days, you know there are better ones coming. I don't know when those better ones are coming. I thought we had had some better ones. They started to go backwards. Definitely had a little cry, got past it. Better days are coming. I don't know if it's this year, next year, but we are going to get through this. We are going to get through this together because we will work together as a team. And I think that's the biggest thing that I wanted to relay today. Next slide, thanks. Here's my contact information. Don't ever hesitate to reach out. I'm very good at forwarding emails to whoever on our team to respond, so don't be afraid. A lot of people say, well, didn't want to bother you. Bother me, I hit forward, it's completely fine. Like, truthfully reach out, and if it's something that I need to handle, I first one to step up and handle it. We want to help and support. One more slide, please. Or two more, I'm sorry. Summaries, which are based on our Healthcare Coalition regions. These will start being shared weekly through the healthcare coalitions that are specific to your region. So we probably will tweak them as we get feedback. We want to add some EMS data into this as well. We also can do some county information, and likely we'll be posting some of that more publicly in the coming days. But I just want you to be aware, if you're not on your coalition's listserv, these are going to start coming out probably on Thursdays. So you'll be able to start receiving that information. That's everything that I have. Any questions? Yes. Yeah, that's $1 million question. So I'll just repeat it for the group. How many of these patients in the hospital are vaccinated or unvaccinated? We are actively working on getting that information. Anecdotally, we know what we're being told. What we don't have is kind of the hard data. So one of the very large health systems in the state told us that 94% of the hospitalizations were unvaccinated. We do know on the deaths, because the deaths all get investigated, the number is even higher. So we know that vaccination is stopping hospitalization and death. That is huge. That is key. That is the message. So that's a really, really great point. I think one of the things that we're trying to do is say over the last, I believe we're going to go back to May 1st, how many of the new admissions were vaccinated or not. And let me be clear, fully vaccinated. So 2 weeks post whatever vaccine you chose. And we're going to look at sort of where we go from there on a weekly basis. So we keep looking at those numbers. We do know that there are post-vaccine cases. In most cases, those are mild and are not resulting in hospitalization. The key there, though, is that obviously you could spread it to those who are not vaccinated. And that is where a lot of the encouragement of wearing a mask when you're around individuals and those types of things is coming from. Other questions? All right. Thank you so much.
Okay, thank you, Kimberly. I felt like it was good for us to just get a quick snapshot of where we currently are at. Explain. Okay, all right. So I just wanted to make sure that we got a quick snapshot of where we were at currently. And Kimberly and her staff hammer through this data on a daily basis. Feel free to reach out to her. Feel free to reach out to that team, and they'll be glad to help you with any data that they can get access to. I do want to make a quick announcement in the fact that there are some sign-up sheets going around. If you haven't signed the sheet, be on the lookout for it. If you don't see a sign-up sheet, there's one up here on this front table. Is anybody not signed? So there's some. Yeah, so that sign-up sheet's coming around. If you do not get to sign a sign-up sheet before you leave here, please see Jeff back in the back of the room back there, and he'll make sure that your name gets down so you can get credit for your attendance. But not user error.
Okay, all right.
Okay. Kim says if you're a medical director, please make that notation. If it's nothing but doctor in front of your name, that'd be very helpful. Just so we can make sure that we give credit to all the medical directors. Try it again.
Yeah.
Okay. All right. So we're going to move on and try to move through this. I know that we're standing in between you getting out of here and being able to go back across the mountain. So we're going to talk a little bit real quick about staff updates that we've got, agency updates. Talk about the 2021 legislative session rules update, talk a little bit about Expo, and then Tripp's going to cover some information in his medical director's update. Our new staff, I will say before I get to this staff, those that weren't able to attend the virtual session that we had back in February, I think we had a virtual session. One addition to that here is Billy Langston, and he's back here. Raise your hand there, Billy. Billy has joined our office in our healthcare preparedness program. In addition to these, but we announced him on February, but I just wanted to make that recognition as well, since most people know Billy. Some of the new hires that we've hired since then, we lost our trauma program. We have now hired Heather Majornick. That name may sound familiar to you. Heather used to work for us in education as well as hospital preparedness at that time. She has come back with our office as the trauma program manager. We've hired Brandy Osborne. She just started this past Monday as the information systems coordinator for HPP. Tom Kubel is the supply chain support person with hospital preparedness or healthcare preparedness. He is running the Moxville 2 warehouse for PPE. And then Sequoia Bozeman and Loretta Davis are administrative support people for the healthcare preparedness program as well. We currently have our hospital preparedness operations manager position open, as well as a process and assistant 4 position that we're in the process of trying to get filled. So I'm not doing that, Joe. Okay. All right.
People come in.
Okay. So few agency updates. At one point during COVID early on, we did extend credentials and license renewals. We don't have any plans to do that anymore at this point, hoping that the COVID variants will continue to be on the decline, or we'll get out of this without having to do that. The 131E 158 staffing waiver that many of you are aware of, it is currently scheduled to sunset 30 days after the expiration of the governor's state of emergency. The governor's state of emergency is currently through the end of this month into September, which would carry us to the end of September when this 131E 158 waiver would currently expire. For those of you who may not be familiar with the 131E 158 waiver, it's basically allowing you to operate an ambulance with one person that's credentialed on the truck versus the 2 credentialed personnel that's currently required on the truck. That has to be requested through the EMS system. So the system is aware that an agency within that system is using that waiver. And what we're encouraging is to think outside of the box on who that second person is. Don't pick up the local homeless person off the street and decide you're going to let him drive your truck. Look at people, maybe like I was talking to somebody the other day, the public school bus drivers, electrical department within municipality or county or any other county type of employee, someone who knows how to operate and you feel comfortable operating your ambulance would give you that flexibility to cut down to 1 credentialed person on the truck. Obviously, that other individual on the truck can assist in loading the patient, assist in putting the patient in the ambulance, but can have no responsibility whatsoever for patient care. Whoever that credentialed person is that is on the truck is responsible for total patient care. This is just one of the things that we're trying to allow you to do to be able to get over this staffing shortage. With the recent surge in cases, we may end up trying to extend that waiver. I'll be very honest, we were in the process of trying to make the waiver go away as the numbers were declining, but we weren't able to do it because it is tied to a state of emergency. So it was going to sunset 30 days after the state of emergency, but now in the past week, we've probably had about 4 systems that submitted to be able to use this waiver to help them with their staffing shortage. So as long as it's being used, we're perfectly fine with that. I think where we were trying to keep from is obviously it being abused, because we know that anytime you open that door, there's also the possibility of it being abused, where people would use that waiver to be able to save money versus trying to take care of the staffing issue that they're addressing. So it is currently in place, and you just need to go to your system to try to request it if an agency within the system is interested in it. We are currently still involved in the COVID process. We are still running the Moxville 2 operations warehouse, which is where the PPE is being distributed and shipped across the state. So if you're in need of any PPE type of supplies, then feel free to put in a request for those supplies. I can pretty much assure you that EMS will not get denied because we're running the warehouse. So I think that's pretty much been the one caveat of us running this Moxville 2 warehouse. And one of the reasons why I think, we really haven't pushed back a lot on running this PPE warehouse, because of the fact we knew that if EMS needed PPE, we knew where we could get some from. So if you need PPE, feel free to reach out, submit the request, contact an office, and we'll try to get you in touch and get the proper supplies that you need. We also our office and Kimberly's staff is also responsible for all the daily data reports that you see on all the dashboards and you see publicized throughout the news media. So let's talk a little bit about the General Assembly. We could probably use the rest of the time talking about the General Assembly, but they did return to session on January the 27th. During that time, since that time, the House has introduced 971 bills. The Senate's introduced 730. So there's been 1,700 bills that's been introduced since they come back into session on January 27th. 23 of those bills were related to EMS. 72 of those bills were related to public safety. 23 bills related to EMS is probably the most bills that I've ever seen since we've been monitoring EMS bills in the General Assembly. We'll usually hit 10 or 12 or somewhere along in there. But there were periods of time where it was really busy trying to keep up with the bills that were in the General Assembly. So I'm going to hit a few of the bills that I think, you may be interested in. To be honest, the 23 bills that were introduced, a lot of the bills never made crossover. And the ones that did make crossover haven't made a lot of progress since they hit crossover. And I'll explain a little bit about that. But House Bill 48, Senate Bill 134 was talking about concealed carry for EMS personnel that were doing tactical medical operations. That bill crossed over from the House into the Senate, and the Senate bill crossed over from the Senate into the House. So they crisscrossed and they did make crossover. But as you can see, the Senate's sitting in committee. And there's a little bit of slide later, but I'll go ahead and tell you the reason why the House hadn't voted on theirs is because they want to make sure that the Senate's not going to leave theirs sitting in committee and go home. And so the Senate is currently, the House is currently waiting to vote on the Senate bills because the Senate's been tied up in budget, because the Senate has to kick their budget out first. So all their people been tied up in budget. The House has decided that they're not going to move a lot of bills because they're going to wait and make sure that the Senate isn't going to do the budget and go home and leave all those bills out there hanging that they passed. And so they're going to wait and see kind of what's going on the other side. So I do anticipate that this bill here will become law, but it really doesn't have any impact because in administrative code, it already says that tactical medics can carry concealed carry, and they just all that bill that's in there. So no, it's not a whole lot of impact at all to EMS. This protect those who serve and protect is the bill to increase the punishment for discharging or attempting to discharge a firearm into or at an unoccupied emergency vehicle. And it also increases the punishment for pointing a laser device at a law enforcement or emergency personnel. So that bill was a House bill. It crossed over to the Senate. It did pass, but it's sitting in the Senate right now again. And that bill, I feel like, will probably pass as well. Shouldn't be any really opposition to it. Don't really see any issues once it starts moving. There's an Austin law bill out there, House Bill 315, that imposes that Class F felony for somebody doing an unlawful burning that results in the injury of an EMS person or law enforcement or firefighter or a fire investigator. And then the bottom part of it just talks about background checks, but it's mostly related to the fire service. It crossed over from the House to the Senate as well, and it's sitting in committee. And I think it'll probably come into play. Really doesn't have a lot of impact to us on the second part because we already run background checks. So shouldn't be any major issues there. Senate Bill 62 is that volunteer fire department preservation, basically talks about increasing the pension fund payments for retired people. The best I can tell with that bill, it didn't make crossover. And so the bill is dead unless it gets gutted from another bill that did make crossover. But I do know that this is one that Joel and the North Carolina Association of Rescue and EMS and Fred Bone and their legislative lobbyists and all those people were pushing. And so with those people pushing, the reason I wanted to put this on here is I wouldn't be surprised if they don't get a little bit of pull over in the Senate to get that bill gutted, in the House to get that bill gutted from another bill and insert this language and try to get that through. So I put it up here. It didn't make crossover, but I wouldn't be surprised to see it surface. This House Bill 694 is a healthcare power of attorney bill. Really strange bill. Bill requiring that employers require employees who must respond to first to emergencies. They must have a healthcare power of attorney on file, and it must be updated annually during the review process. So that means that every employer, every county, or whether it's a private, whatever, every employee is gonna have a healthcare power of attorney on file with the county. And every year when they go through the performance evaluation, it's gonna have to make sure it's gonna be updated. Really strange bill. We didn't really know where the language come from. We done a little bit of research, found out this all started based upon a Raleigh police officer getting injured in the line of duty. At one point, we done some paperwork to try to oppose the bill, just because we felt like that it was really didn't serve any purpose. It was going to be difficult for EMS agencies to maintain, but it crossed over from the House to the Senate. It's sitting in a committee. It may become law. It may not become law. I did put up here the thing that was a little bit strange that does concern me is it passed the House on a unanimous vote of 113-0. So it does have a lot of support. It very well may gain legs in the Senate and may breeze on through and could become law, but it is out there, and the Senate has not done anything with it yet. There's another bill out there that House Bill 648 that talks about an exemption to the practice of veterinary medicine for emergency personnel who render EMS to an injured canine law enforcement or an injured search and rescue dog at the scene of an emergency. Again, kind of come at us from nowhere. We weren't aware that there was a bill even being discussed about this. It went through the House, jumped over to the Senate, is sitting in committee right now. And it very well may gain traction as well, because you can see there that it passed the House 112-0. And so it does have some support as well. And then there's this stroke bill that many of you may have heard of, Senate Bill 683, which was a pre-hospital stroke bill for EMS personnel, and it was requiring Department of Health and Human Services to adopt rules concerning pre-hospital stroke protocols for EMS personnel. Really didn't make a lot of sense, because that's what we already have. We already have inset protocols. We already have protocols. And for some reason, this particular bill here focused a lot on large vessel occlusions. The bill, throughout the entire wording of the bill, mentioned large vessel occlusions on several different occasions. And so we know where it came from, but we don't know actually what stemmed the conversation. We do know that this very same bill, identical language, was introduced in about 5 other states. And so we don't know if somebody just picked it up from another state and said, you know, this would be really good for North Carolina, and shot the same language. The language was identical, but anyway, we opposed the bill in through our legislative liaison. Stroke Advisory Council got involved. The North Carolina chapter NAEMSP got involved. Stroke Advisory Council, which is a state committee that's made up of personnel through the General Assembly, they weren't even aware that the bill was going to be introduced or what was there, and that's the whole purpose of that committee. So the Stroke Advisory Committee is trying to work with the legislator who introduced the bill to try to make sure that the issues are addressed, and if they continue to want to push it forward, it will be something that we can live with, and it doesn't really affect what we do. So that bill is out there. It did not make crossover. That's a good thing. Don't know whether it'll come back up again, but I wouldn't be surprised if it doesn't come up the next legislative session. So we are still monitoring the bills. They're, as you can see, there's a lot of bills that's over in the Senate, and there's some that's over in the House, but most of them are over in the Senate. They're sitting in committee. We'll keep updated on those particular bills and stay focused to make sure they don't introduce anything crazy and gut another bill. But they're focused on the biennial budget right now. So once that's finished, they'll begin to address those bills. As I mentioned earlier, the House is pausing to make sure that the Senate takes up their bills before they go. There's rumors flying around that they'll probably go home about Labor Day, and then they'll be back in October and November to focus on redistricting legislative maps. So that'll probably occupy all their time from October to November, maybe even into December or whatever. But I think whatever happens between now and Labor Day is probably what we'll see happen this legislative session. So switch gears a little bit over to our data system. I think last time we talked, we were in the process of finalizing our contract for our data system. We did finalize that contract in February of 2021 with ESO. After we dissolved the EMS PIC, then we were required by the state to bid out our data system within the first 12 months. We started that process. That process is a long, drawn out process with the state. It took about 2 years to do it. And now since February, we've been trying to figure out all the things that we want to do in the data system and all the improvements that need to be made. And we're trying to work on trying to hammer those out. So please bear with us as we get our data into a better place. Also wanted to bring up real quick about this CAS GVS issue that many of you may have seen a letter come out from myself not too long ago regarding this bypass alarm switch. That's a lot of your final stage ambulance manufacturers are indicating on the CAS sticker that's on the ambulance that the vehicle is fully compliant with all the CAS standards, but the vehicle is equipped with a backup alarm cutoff where you can put the truck in reverse, hit the switch, and it'll shut the sound off. That's against CAS's standards. And so if they do that, they are supposed to note that the final stage ambulance manufacturer is supposed to note that as an exception or variance on the sticker, so that when you buy the truck, you know that it is not 100% CAS compliant, and you can make modifications, whatever, based upon that. You may get in variants or exceptions to the sticker, and the CAS standard is pretty common with like stretcher mounts. You may already have a stretcher that you're going to put in your new ambulance, and you need to buy the truck without the stretcher or without the stretcher mount, and then you're going to have that put in. That would be an example where there would be a variance or an exception to a cast standard, because when you look at the cast standard, it says that the stretcher, the cot mount, the stretcher itself and everything comes with the truck. So anything that's not on the truck that's according to cast has to be listed as a variance or an exception. This backup alarm bypass switch should be the very same. However, you cannot have that in the state of North Carolina on a new vehicle. Any new vehicle, it's the adoption of the cast standard, that switch has to go away. So any truck that's recently been purchased, we're trying to get information from the final stage ambulance manufacturers and work with you guys that do have those trucks to make sure that they correct their mistake and take that switch, either disable the switch, replace the switch, whatever they need to do. Because right now we've permitted trucks according to the cast standard that didn't meet cast standard because of this issue. This does not apply to remounted trucks. Remount trucks are exempt. If it's a remount that you sent off and you've got that bypass switch on the backup alarm, that's perfectly fine, because it's remount trucks are currently exempt from the standard. That may not always be that way, but any trucks that you've got that's currently got it now, that are older trucks that you purchased new, they're fine. It's any new construction trucks that you purchased after the implementation of this particular standard. We're currently gonna work with you on that permitting. We obviously can't put the permit in the windshield and on the truck until that issue is resolved. But we understand that there's trucks out there that's being sold that's got the bypass switch on it, and it doesn't have it listed on the cast sticker. And we're gonna work with you to try to get those issues resolved. So real quick, EMS Expo, I wanted to make you aware of the dates, April the 29th through May the 4th of 2022. We are making plans to have a face-to-face conference in Greensboro again on those particular dates. We do currently have call for presentations open. We are planning for the preliminary paramedic competition. We are planning all the things that we had pre-COVID, post-COVID, that we can bring back to EMS Expo April 29th to May the 4th. I also wanted to bring up to you about the 988 suicide line. A lot of you have heard of the 988 coalition. Basically, the Department of Health and Human Services, Division of Mental Health, Developmental Disability, Substance Abuse Services is what that big acronym up there is. Was recently awarded a grant to support the implementation of the national 3-digit dialing number for the National Suicide Prevention Hotline. They are partnering with call centers across the state, and we'll be working on this project from now till July of 2022. And they're asking for some assistance with that particular project of anybody who is interested, has experience or any expertise, and is wishing to help with that project. Please feel free to reach out to us, and we'll put you in touch with the people that you need. This is the lady here that's leading that effort, as Susan E. Robinson. You can either get her contact information from us, or you can get it off the presentation here. And then, of course, Mackenzie Beamer from our office is represented on that committee as well, to make sure that EMS does have some representation, and any monies that they may have they want to bring EMS's way. We'll be glad to assist with that. So with that, real quick, I'm going to turn it over to Chuck and let him run through the rest of it. What all that? Is that right? Use your mic. Okay. Do your deal. Shut them down.
I think I know how to operate one of these things. All right. So, in spite of COVID, I know that's been top of mind for everybody. Over the past 18 months or so, our regulatory staff has continued to do their normal, regular, everyday duties in addition to a lot of stuff that we've piled on top of them for the COVID response. So I think there's a big kudos that needs to go out to our regulatory staff and the work that they've continued to do. They've done a lot of double and triple duty. So those guys have really pulled a lot of weight here. So here's an opportunity to thank them for what they do. Couple things want to just go over. First off, we've seen for the past 12 months or so, we've seen an uptick in complaints and issues related to EMS professionals carrying weapons on vehicles. So we just wanted to take a minute to remind you that there are 2 rules that are specifically in place related to weapons and explosives on ambulances. Administrative Code 13P 206A, prohibited, should not be on there. 216E, if you are part of a SWAT team and in the performance of those duties, then those weapons are allowed, but they should be in a locked outside compartment box and they're not accessible inside of the vehicle. So just a quick reminder there, that's something that for some reason we've seen a bit of an uptick in over the past, past year and a half. So a couple of things also to bring up. Happy to announce that individuals that are taking their credentialing exams are now getting those results real time. As soon as they're completing that exam, they're now seeing that they have either passed or they have not passed that exam. Todd was telling me yesterday we had an individual last week before, that finished their exam, saw the results on the screen when they finished, walked out, pulled up their continuum profile. They had their credentials. So we're now issuing credentials essentially full time, unless you're outside of the state and you have the background check that you have to go through, and we're waiting on all that. So that is much improved from the days whenever we had to wait 4 to 6 weeks. Did you get the big envelope? Did you get the little envelope and all that kind of stuff? So y'all remember that. There's enough gray hair in here to remember that, I can tell. So that big leap forward there on credentialing. I think that's important to you as administrators. We know that staffing issues continue to be a problem outside of the COVID realm. So now if you're sending those folks to get those credentialing exams, we can speed that up. So that's been a huge benefit there. And those are the messages that they get, the Dear John letter. A few other things effective January the 1st, 2022, when students are obtaining field time or skills, they must be assigned as a third person on the truck. I think for years we've made some exceptions and some provisions for individuals that if they were working, they were on duty and they were in a class, they could perform some skills and do some things as long as they were being precepted by a partner. So now we're kind of shutting that down. Those individuals do need to be listed as a third person on that ambulance. If we find out that that's been an issue, then some of those skills or some of that time could be negated and wiped away. Also on some education stuff, instructor workshops. We're going to continue doing instructor workshops via the virtual platform until further notice. That seems to be working pretty well. It gives folks some additional options and are not tied to geographic locations. So if Todd and those guys are doing a instructor workshop and you live in Murphy or you live in Manio, it doesn't matter. You can still attend that. We did have a waiver in place for those instructor workshops. If your instructor credential was about to renew, we hadn't been doing those workshops because of COVID. That is going to expire on August the 31st. So if your instructor credential is set to renew after August 31st, you do have to have that instructor workshop. And again, those are on a virtual platform. We've got those posted in Continuum, so please go check that out if you need that, or reach out to your education specialist, San Juan Timmons, Robbie Amerson, Tanya Poole, or Todd, and they'll be glad to help you get signed up for those and make sure you got the information you need to participate in that. Program coordinator workshops. Reminder, this is an annual requirement. We done one. Did we do 1 or 2 here? We done 2 here. We're going to be doing 2 in Wilmington coming up in March. And we'll also be offering 2 at Expo. So if you're a program coordinator and you need that workshop, trying to provide plenty of opportunity for you to get into those classes. Couple other agency updates. We've continued to do a lot of work on the mobile disaster hospital. For years, y'all know we've been operating out of some of those soft-sided Western shelter tents. We have now purchased some hard-sided structures called forts. Roger Kaiser led the way on getting those purchased, developed, and designed. And so we've got those in place now. So our mobile disaster hospital is in a much better facility, so to speak. A lot of portability, a lot of different options that we can do with that. And it's really impressive to see that. We've also worked to develop some mission-ready packages based on specific needs so that we're not just sending, we're not throwing spaghetti at the wall and see what sticks. We've got some specific mission-ready packages that can go out. Here's a picture of the inside of those forts. Those things just basically marry up together, and we can put, I forget, 5 or 6 of those together, and we can create some flex space, ICU space, ED space, a lot of different options with that fort product that we've been able to put together. We're currently updating our emergency operations plan, some appendices and annexes. We've got a big exercise plan here for later in the month that our staff and some of the emergency management folks are going to be participating in to exercise some of that. Fortunately, we've not had to work through much hurricane issue over the past year or so. Not like we've not had anything to do. So getting prepared for this year and going into the future so that we're ready for those things. EMS for Children, we continue to work through that grant. That it now lives over on the HPP side. So we're managing that from over there. I think we've sent out an assessment to all hospitals. We've got about 90% response rate. We used to do those assessments about once a year. We'd send out a survey on some EMS for Children stuff. So your hospital should have that in place. And we've got staff that's been working through those to get the information back. This is kind of new. For years, y'all know that we have kind of doled out protocols a little bit along. There may be 1 or 2 come out that's been revised today, a couple more come out that's been revised in a month or so. We're going to start kind of compressing that down into 1 rollout per year. And those protocol rollouts are going to be happening on September the 5th of each year, starting in 2020. September 15th of each year. They're going to be rolled out. And so that way you'll be able to see everything that's new at one time. We've had a lot of issues with folks would miss a rollout. They would miss an update. They would find out about it, 6, 8, 12 months post. Well, we didn't know you'd change that. So we're going to compress those into one rollout per year, September the 15th of each year. When those protocols come out, you'll have until January the 1st to adopt or revise those protocols. The process remains the same. If you want to make revisions to those have to be submitted. They go back to Dr. Winslow for his approval. There's negotiation between the medical directors. However, those guys end up working that out. And then that protocol has to be adopted by January the 1st of the following year. We're also working diligently to move our airway submission forms to an electronic format instead of having to send in those airway forms like we've done for years. If all the parameters are met, it's been a clean RSI. There's not been any major issues, no check boxes. We're not going to need to see the PCR on that. I think that's going to streamline that process for a lot of folks and make that a little bit easier. We're getting into that season, that every 6-year season, whenever we have to renew those EMS system plans per rule. Our staff have been going out and doing a lot of EMS system reviews, sitting down with administrators, going through that system plan and all the different components of that plan to make sure you've got stuff in place, offer suggestions, help you find resources, borrow resources from you that can be shared with other systems that may need that. So we're kind of working through that season right now. So some of our regional staff may be reaching out to you, want to come in, sit down and look at your system plan. Not a punitive thing in any way, shape, or form. It is just a consulting visit so that we can help you work through, make sure that renewal, whenever that comes up, is nice, clean, easy, and goes really, really smooth. Also, we've got some alternate practice settings. We've had some notification of some EMS professionals that are in alternate practice settings that are performing outside of their scope of practice. If you know of EMS professionals that are working in doctor's offices, clinics, dentist offices, ERs, whatever the case may be, you get a chance to have a conversation with them. Just remind them folks need to stay within their scope of practice and don't need to be sliding out and doing things that we don't have approved for EMS professionals in North Carolina for their particular level. Also, our systems group is working diligently to try to advance everything onto a digital platform so that we can get away from paper. We've been accepting virtual signatures on paperwork for a while now. I think we're going to continue to do more and more of that thing so that we don't have this paper that's just kind of floating back and forth through the U.S. Postal Service, which has proven itself to be extremely efficient lately. System modification documents have transitioned into a PDF fillable form. And also we've broken those things out to the component that you need. You know, for years, if you needed to add a provider, we would send you like a 30-page document that included everything from protocols to medical directors to EMD stuff. We've broken that out now. You tell us what you need to make the change on, and we're just going to send you that section. You don't need all that other junk. There's no need in sending that. It's just a waste of time. So our guys have worked to break that out so that we can be a little bit more streamlined on managing those system modifications for you. Couple of changes to rule. Again, we've been working diligently through the regulatory process. Educational programs, initial advanced EMT and paramedic programs must possess a letter of review from CAEHP or possess CAEHP accreditation. That rule is effective July the 1st of 2023. We adopted a new set of rules, or we adopted some rule changes back on July the 1st. There are some in there that we have got an extension on when those rules come into effect. We'll talk about what those extensions are here. But for the most part, our new rules did come into effect July the 1st. Also, level 1 instructors must now hold at a minimum of an associate's degree. That's effective on January the 1st of 2022. Level 2 instructors must hold a bachelor's degree. That's effective January the 1st of 2022. If you currently have a level 1 or level 2 and you do not have the appropriate degree, you are grandfathered in. So you don't have to worry about going back and getting that. Don't let your credential expire. All instructors credentialed by the effective date of the rule will be grandfathered, only applicable to initial credentials again. Lapsed EMS credentials. You know, for the past number of years, we've had this kind of funky thing that if you were a medical responder or an EMT and you expired, you had, what was it, Todd, 24 months?
24 months, and then after that, you have to go back.
Yeah, after 24 months, you expired, you had to go back and take the course again. If you were an AMT or a paramedic, you had 48 months. That created mass confusion. So we have compressed those all down to 36 months. So no matter what your credential is, if you expire, once you cross that 36-month threshold, then you have to go back to the beginning and start over. So you've got 36 months to go back and get that credential renewed if you let it expire, or bad things are going to kind of happen to you. Basic and advanced institutions must complete at a minimum 2 courses at the highest level approved. Had a number of institutions out there that were approved to teach advanced EMT and paramedic courses, but hadn't taught an advanced EMT or a paramedic course in as much as 12 years. And so now if you're approved to do, let's say, advanced EMT courses, then you need to do at least 2 of those per year. So if you've got any questions about that, Todd and his folks are glad to explain a little bit more about that for you. All instructors credentialed by the effective date. Did I go forward?
Courses every 4 years or 4? It's for the term of that credential for the institution.
For the approval of the educational institution. So the question was, does that apply? Is that every 2 years? So you must teach at least 2 of those courses during the approval period of the educational institution. And those approval periods are 4 years. So you would need to teach 2 courses at the highest level within that 4-year period. Now, I'll make a caveat here. If you're approved to teach AEMT and paramedic and you teach 2 paramedic, you don't need to teach 2 AMT. So you have to teach at least 2 at that highest level. Does that make sense? Okay. We made some additional changes to Rule 1507. This is Melinda's rule. This is the one that she kind of lords over. You know, Melinda. Violations regarding EMS personnel credentials. We've added theft from an EMS agency or educational institution as an actionable offense. We were seeing students that were walking out with bags of fluid, equipment, that kind of thing, putting it in a personal vehicle. Now we've added that specifically as a rule violation. People should know that's a no-no. I don't understand why taking things, you think that's okay. But anyway, added diversion of any medication required medical oversight as an actionable offense. We were seeing lots of diversion of things like Benadryl, Zofran, and that kind of stuff. Since they weren't narcotics, folks didn't seem to be taking that very seriously. So we've now added any medication that falls under that medical direction. Any diversion of any medication is an actionable offense. And also filing a knowingly false complaint against an EMS, against an individual, agency, or educational institution. So if you come to us and you just flat out lie about something, then we can take action against your credential if you've not been truthful on filing a complaint. Also, 1507, this is a big one. For years and years, I've been asked the question, I think a lot of our staff have been asked the question, as an administrator or medical director, do I have to report? And there was never any language in there that compelled you to report a violation of staff if they had violated an OEMS rule. We've now put that into place. The EMS system administrator, agency primary contact, medical director, education program coordinator, or medical advisor shall notify the Office of EMS of any violation listed in paragraph B of this rule. Now, there's not a time frame in there. So if you have a violation locally that needs to go through your quality management process, it needs to go through your disciplinary process locally, needs to go through HR, whatever the case may be, you are certainly fine to go through that process before you notify us, but we should be notified at some point during that process. Questions? I hope they're all for Tom. Justin, anything on the chat? All right. Thank you all so much. I'm going to hand it off to Dr. Winslow.
All right. Good to see y'all here today. Appreciate you coming. And once again, just to echo what Chief Mitchell and Chuck and Kimberly were saying, thanks everyone for everything they've done over the last, I guess, over a year and a half now. It's not been an easy last year and a half plus. So thanks for everything everyone's doing. What you're doing is really important. And I really appreciate the opportunity to even work with y'all. So thank you so much for everything you're doing. Joseph was making a last minute change to one of my slides. One thing I want to go over, we can talk about before my slides come up, is just some of the scope of practice changes of the medical board. David Ezell and Tom and Chuck have been helping me go to the medical board for some more scope of practice changes. One thing that's not officially been changed yet, but probably will be changed soon, is the ability of advanced EMTs to push lidocaine through an interosseous catheter for pain. The other thing we're working on is a pilot project for some trauma care, advanced trauma care in Onslow County. We're working with local trauma system down with ECU to try to work forward on a pilot project that will likely get approved. One thing that's probably not going to get approved in the near term will be antipsychotics as a class, but we're going to work through that. That might happen, but we'll kind of regroup on that to kind of see where we want to go with that, if that makes any sense. So any questions about scope of practice before we move forward?
Dr. Winslow, we did have one question in the chat, back to what Chuck was talking about. As long as one person at the agency reports, everybody's good. Is that correct? Can you just?
Chuck says that is correct.
So as long as one person reports, yeah. Repeat the question.
Can you repeat the, okay. I can't remember that question.
I'll answer it. I mean, I'll look at that.
Okay. I'll screw that up. Trust me. Charles, why are you laughing at me? Oh, okay. Thank you. So do I advance or do you?
You try first.
Oh, boy.
That's how this works.
We'll see how this goes. So a few topics we want to talk about today. Some new research has been done in EMS lately. Can't do this without talking about COVID. Some possible ways EMS might help intervene in some of the cycle of violence we're seeing in our communities. Already went over scope of practice changes, so we went ahead. Protocol changes, we don't really have many to show on here today, so that's quick. And then some ketamine data, which the regional specialists have been really great about getting together. We're going to go over that briefly. That's pretty reassuring, actually. So nothing bad there, other than don't feed your patients cookies before you give them ketamine. Yeah. So Precedex or dexmedetomidine versus propofol for sedation. I've been getting a lot of questions from EMS agencies about whether I can go to the medical board and ask for Precedex. At this point, if I had to go to the medical board and ask for Precedex, you'd probably find me under a table crying. So at this point, I'd rather not go to the medical board and ask for Precedex. I don't even have a lot of experience with myself and our ED using it. So I decided to try to find some research on this. The interesting thing I did not know about Precedex is, at least in the test tube, it has antibacterial properties. So they assumed that maybe Precedex would be better for septic patients. So they did a head-to-head randomized trial looking at Precedex versus propofol for septic patients, and there was really no difference. Ventilator-free days were basically the same. Secondary outcomes, death at 90 days was basically the same. And number of days alive without delirium or coma were basically the same between the two groups. So there's really not much difference between the two. So I don't see a lot of, I'm always open to going forward to the medical board for more stuff later on. But right now, I don't really feel like, based on the data, we have a lot of big reasons to go and ask for Precedex. And that's mainly that'd be for interfacility transfers. What'd I do? What was that, Joseph? I'm standing by. All right. So other things, we're always looking at innovations, especially pay attention to what we do with kids. First pass success is very important. Some studies show that after the third or fourth attempt with a kid, when you're trying to innovate them, your chances of a complication are like 60 to 70%. So if you get that innovation on the very first try, your complication rate's a lot lower. This was a study done in Boston Children's Hospital, which is one of the best children's EDs in the country, if not the world. And they were looking at first pass success, and that only happens about 80% of the time in general. They were only using CMAX, and they were basically noticing that first pass success was obtained 73% of the time. 19% of their patients required, that they didn't get it on, required 2 attempts, and 18% or 8 required more than 3 attempts. And their best predictors of success was MAC blades, better than Miller, and it was higher when they put the MAC actually in the vallecula. So that's just something to keep in mind. So first pass success in kids is very important. Anything you do to maximize that, it's better. Of course, we've also got a lot of research which shows that innovations and advanced airways in kids really don't help that much. And I actually prefer bag valve mask. In fact, when I've worked in the peds ED, my general experience was all you really need is a bag valve mask, because that will get you through almost all the time. Sometimes you have to intubate kids, but bag valve masks are very effective in kids. I thought this was really interesting, comparing 2 different intravenous doses of ketamine for pain. They looked at the 0.15 mg per kg versus 0.3 mg per kg. My experience in the ED using ketamine for pain, I've always thought the 0.3 mg per kg would be much better. And they gave it over 15 minutes. I usually give it over 10 minutes. And they actually noticed the pain control at 15 minutes was actually better. I'm sorry. Yeah, 15 minutes, the pain control in the 0.15 mg per kg group was better. At 30 minutes, it was equal, and the complication rates in the 0.15 mg per kg rate were lower. So I'd always thought we should be going more for 0.3, but this study is actually randomized, prospective, showed that you're better off the 0.15 mg per kg dose. And I have had some bad experiences back before I knew what I was doing with ketamine. I gave the 0.15 mg per kg dose the first time I ever used it. And the patient's friend was in the room, and the patient was saying she was going to die. She was seeing Jesus. She was seeing all kinds of things. The friend's freaking out. I'm freaking out a little bit. I'm bringing the friend my coffee, saying it's going to be okay. Fortunately, the patient didn't remember any of that. But just remember, don't give the 0.5 mg per kg dose with ketamine. That's why we have the low doses. You either in for a small amount and to give them a little bit of pain, medicine for pain, or you want to knock them completely down. So you're in for a penny, you're in for a pound, but do not give the 0.5 mg per kg dose, and use me as an example of what not to do. That's what I tell my kids. So COVID, vaccines. The only way we're going to get out of this and get back to normal is if everybody takes the vaccines. I'll sum it up. Basically, the COVID vaccines are safe. They're effective. I think we've gotten about shots in about 350 million people at this point. The only thing keeping it from getting a full approval is just the bureaucratic process. It's a safe vaccine. They've used existing technology to create the vaccines. They're good vaccines. You will not get COVID from the vaccine. There's been kind of weird rumors out there that the anti-vaxxers made up and put it on a website saying that it could affect fertility. It does not affect fertility. If anything, if you're pregnant and you get COVID and you don't have the vaccine, there's a good chance you're going to lose the baby. Also, they keep saying, certain vaccines like maybe J&J can increase risk of blood clots in women. If you have COVID and you're female, there's a good chance you're going to get a blood clot, or at least small amounts of blood clots. And if you're postpartum with COVID, you're already at high risk for blood clots. If you have COVID, you're going to be much higher because COVID infects the small vasculature. And if you're really sick with COVID, you probably already have some small PEs you'll never know about. So it's really important to get the COVID vaccine. So that's just something to keep in mind. I did not know this. This is one of the researchers who helped develop, I guess it's a Pfizer vaccine. She's actually from Hurdles Mill, which is where I grew up. My family still farms tobacco. That's Dr. Corbett. So these are really safe vaccines. Both Pfizer and Moderna use messenger RNA methods to make the vaccine. It's a very proven method of making vaccines. The third vaccine, Johnson & Johnson, uses a DNA method. The vaccines do not insert DNA into your cells. They do not change your DNA. They use your own cells to make a copy of kind of like the spike protein so your body can get exposed to that and then make an immune response to that quickly if you get infected. So these are all using proven technology and they're very safe. So Pfizer and Moderna, like I said, cannot give someone COVID. You use messenger RNA. They do not interact with your DNA in any way. Johnson & Johnson uses a slightly different method. It's more of a DNA type method that they use when developing other vaccines for Ebola. Already proven technology. That's why they're able to do it so quickly. They're safe vaccines and we need to take them. So with COVID vaccine, you don't want it. It can cause all kinds of stuff. The Delta, it's about 1.8 times more infectious than the Alpha. There is no more Alpha, basically. We're now Delta. If you're saying it's COVID, it's now Delta. It's also about 1.8 times more effective more likely to put you in the hospital. So it's also more severe. You don't want that either. It's really infectious. It makes you sicker. So there's about 90 million people in the United States who have not been vaccinated yet. In fact, if you look at, and the higher the vaccination in your community, the safer you are, whether you're vaccinated or not. I was listening to Chris Ohl. He's the main infectious disease doctor at Baptist. He actually trained with Fauci. I was listening to his talk yesterday. Or this might have been Michael Osterholm with CIDRAP, who's also a major infectious disease doctor. One of those two podcasts. They're saying if you took Louisiana, which has about a 30% vaccination rate, and you made them their own country, right now they would have the highest case rate in the whole world. And so we have to get the vaccination rates because right now COVID, the new COVID variant, is so infectious. If you goes to a population who's not vaccinated, it's going to basically be going through one of those really dry forests in California, which is burning. It's just going to go right through it. That's why in England, their infectious or vaccine rates are a little bit higher than ours. And they had it's like Kimberly was saying, they had a big, huge spike and then went down really quickly. So that's what they're hoping will happen here is we'll have a big spike and it'll drop quickly. But the only way we're going to really get through this quickly and get through back to normal is if everyone gets vaccinated. So some cardiac issues in COVID. COVID infects your small vessels. It gives you an increased risk for MI. It also causes myocarditis, which can cause arrhythmias. Also with your patients with COVID, keep an eye on your long QT because COVID patients are more prone to arrhythmias. The systemic inflammation actually causes a long QT, especially myocarditis. You get increased potassium waste in urine. That drops your potassium. Diarrhea, dehydration drops your potassium as well as just a systemic inflammation. And another interesting study they did in Germany. They looked at post-COVID patients on average about 71 days after their infection and did MRIs of their heart. And it's a German study, and it's around 100 patients. 80% at 71 days still showed some cardiac involvement, and 60% still showed some inflammation, which is not too different than an athletic study they did on Division I athletes near the beginning of this pandemic, who I believe they're all symptomatic, but they showed a really high incidence of myocarditis around this same time period after the inflammation. So that's just also something to keep in mind. So effectiveness of COVID vaccines against Delta. There was just now an article which came out in the New England Journal of Medicine. I think it was this past Friday. I went back through it. And they only looked at symptomatic subjects. And this is back when there's still a lot more alpha out there. There are 14,837 samples of alpha, 4,272 samples of delta, at least in the patients they got it from. So it used to be a single dose of Pfizer with the alpha variant was about 47% protective 2 weeks after your first dose of getting basically symptomatic or getting COVID. With the Delta, it's one single dose, not full vaccination. One single dose is about 30% protective. 2 doses is still 88% protective against the Delta variant. This is kind of a hard slide to see, but this came directly from the article, so I couldn't change it, make it better. Over here, you see this is a single dose. This right here is the alpha variant, and this is the beta variant right there. So when the alpha variant was predominant, one single dose got you around 48% protection. The confidence interval is a lot wider here. A single dose of Pfizer against the Delta variant is pretty wide, but it's definitely lower. Over here, you see this is, make sure I'm going straight up. Yeah, this is right here. For the alpha variant, you're about, in the mid 90s, and it's a little bit lower for the Delta variant. So they're still effective, but just not quite as effective. So if you look at the LA data, they show that you're about 10 to 15 times less likely to die from COVID-19. This is the Delta variant if you're vaccinated. When I've made this slide, this has changed a little bit. 100 million people in the US were not vaccinated, and really they're basically making the point COVID is just going to burn through them. If they don't have it yet, they will get it. That's just the way it's going to work. So you have to get vaccinated, and it's a heck of a lot safer to get vaccinated than it is to run basically playing roulette with what COVID is going to do to you. I mean, we've had, where I work, there are people in their 30s who died from COVID who had no comorbidities. So you need to keep that in mind. Also know the vaccinated can still spread the disease even when they're sick. And so Dr. Owl, he had a really good comment when I was listening to his podcast or comments yesterday. He basically thinks that if you're vaccinated and you get COVID, it's basically what he calls a COVID cold. So he thinks probably what's going to happen, you get a little of the COVID in your nose, it multiplies, your body detects it, you get a little stuffy, you might feel like you have a little sinus infection, and then your body's already primed to go after that infection, so they knock it out really quick. In the meantime, you can still spread it. So that's why the most recent HHS guidance says if you're in an area with high rates of transmission, which is pretty much the whole state now, that's why they're saying if you're vaccinated or not, you need to wear a mask the entire time, because you could be asymptomatic and be infectious, or you could have what you think is a mild cold and be infectious. So that's why it's important to wear masks inside pretty much in the whole state. And I think there's 1 or 2 counties which are yellow, but everybody else is pretty much bright red. So that's just something to keep in mind. Massachusetts data, this is basically the stress test on vaccines. 70% of the people who went to this big resort community or resort town in Massachusetts out in the Cape Cod, like 60,000 people went to a big, basically one huge party to the whole town. People in bars, dancing together, jumping up and down next to together, singing together. And so this was a really big stress test. The reassuring thing was, although a lot of people still got COVID, even though they're vaccinated, most of them did not get really sick. Out of 346 people that were hospitalized, only 4 of those were vaccinated, and 2 of those had significant comorbidities. In fact, if you talk to people in Missouri and other states where they're really having huge explosions, only about 5% of the about 5% of the positive cases are actually vaccinated. So still 85, 90% at least, probably closer to 95% of the people getting COVID in those areas are not vaccinated. You still get some people who get some symptoms and get tested and they test positive, but they don't usually get very sick. But the people you do have to worry about, immunosuppressed folks, especially lymphoma, leukemia, people with transplants, things like that. They're the folks that are probably going to look at needing to get a booster shot. And once the full approval comes through, which will hopefully be around early September, they're guessing, that's when they can start giving more booster shots, because the Israelis have noticed that in the age over 60 group, after about 6 months, the protection against serious illness in the older groups goes from about around 90% to 80%. That's why the Israelis are starting to look at maybe doing some boosters earlier, just because for the older folks that immunosuppressed, they're worried that the protection might wane a little more quickly. I already went over this. Oh,
You don't have control.
I don't have control. Joseph says I don't have control.
We have some latecomers coming.
So another good quote I heard was basically, this will be a tale of two pandemics, the vaccinated, the unvaccinated. Your chance of dying if vaccinated, and I put this out here, that's 4 zeros and a 3. So 0.00003% is your chance of dying if you're vaccinated. And only about 1 to 5% of the chance of the cases we're seeing in the busier parts of the country are in the vaccinated folks. And your risk of transmitting in a household, if you have COVID Delta variant, it used to be you had about a 20% chance of transmitting COVID within your household if you had the Alpha variant. With the Delta variant, it's about 40%. So I already went over this. So this is the CDC comment about why they're recommending more masking now. It said high viral loads suggest an increased risk of transmission and raise concern that, unlike with other variants, vaccinated people infected with Delta can transmit the virus. This finding is concerning and was a pivotal discovery leading to CDC's updated mask recommendation. So any questions about COVID so far? Well, we're going to get through COVID, but the best way for us to get through COVID safely is to get people vaccinated. And that's going to be the best way to make sure not as many people die. Because if we don't get more people in the state vaccinated, we're going to have a lot more dead people, and we're going to be a lot busier than we had to be otherwise. So we need to get our folks vaccinated. It's very important. So another just note, I think probably because through a lot of the societal disruption we're seeing with COVID, at least where I've worked and everybody else I've talked to, is we're seeing a lot more violence. One thing I was always taught is violence is like a communicable disease. And same thing, I've always heard trauma is a chronic disease. So people who are exposed to violence or around violence are more engaged, or more likely to engage in violence. So 41% of people injured by violence are re-injured within 5 years. 20% of the victims of violence are dead within 5 years. And that's getting a little bit like some of our opioid numbers, to be honest with you. Victims of violence are much more likely to engage in violence, and violence has serious consequences for a person's mental health. So I'm not saying I'm trying to give y'all new roles to do, or I know we have enough to do, so I'm not pushing that. I'm just letting you know that some of the hospitals and some of the trauma centers are starting to think about ways they can actually get in, stop this cycle, because we realize we have someone who's shot or is in a bad situation, and then we send them right back to the same environment with no plans on how to avoid that. I remember once I took care of a really nice kid, and he'd gotten beaten down at school. And I talked to mom, and I was just telling the kid, just try not to go back and beat those other folks up and get back at him. And the mother looked at me and with a straight face, and honestly, my dad might have told me the same thing, I have to admit. No, he needs to go out there and let him know who's boss, or he's going to get beat down again. So he needs to go and beat them up. And I just kind of kept my mouth shut. But those are the kind of things that we need to think about. If there's ways for community paramedics or other EMS agencies to coordinate with the hospitals, or just think of ways we can intervene in that, we need to think about that, because it's probably going to get worse. I know y'all have enough to do right now. I'm not pushing that. It's just something to keep in mind. There have been some studies looking at this. One randomized study in older African-American men, people who are in the program were half as likely to be convicted of any crime, 4 times less likely to be convicted of a violent crime, 6 times less likely to be hospitalized for violent injury, and there's $1.25 million savings in incarcerations costs. Another randomized study looked at 10 to 15-year-olds treated as victims of interpersonal violence showed significant reduction in misdemeanor offenses for a 6-month period afterwards. Chuck's went over that. I forgot to say ultrasound scope of practice. Zach? Y'all doing this, right? Yes, sir. I don't know why he had to clarify that. So you can use ultrasounds for vascular access. There's nothing special about that. I mean, you need a protocol and procedure for it or whatever, but that's within scope of practice. You can also use ultrasound for fast exams and other diagnostic things if online medical control can view those images in real time or within 5 to 7 minutes. Does that make sense? Okay. There might be some other small workarounds I could talk to you about in detail, but that's the basic parameters of that. Any questions about that?
So that's going to require the transmission of an acquired image?
Yeah, that is correct. I didn't say it'd be easy.
I don't know hard.
I never said I got a solution. I just tell you what you can do.
Just repeat what I said.
So Joseph says, with irony, so that requires a transmission? And I replied, yeah. Did I capture that?
Yeah, I'm not sure all hardware offers that as an option.
Joseph says, I'm not sure all hardware offers that as an option.
Period.
Period. Zach, do you have any comments about that?
Most of them do like.
Whoa, 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 whoa.
So if you're looking for the point of care ultrasound, there are quite a bit that do offer that transmission pretty easily. The Butterfly being one. The GEV scan is what we ended up going with because the dual probe offers some advantages there. And do seem to offer pretty safe and secured where you can transmit those images pretty quickly. I know that the Philips, the larger ones that are based off tablets, do still have that capabilities, but you need to have a hotspot or some sort of connectivity, whereas the Butterfly just runs off of an iPhone. So if you have that, then you can use your cell service and get that image transmitted pretty quickly.
Anybody else have any questions about that? Okay. Thank you, Zach.
We have something in the chat that says Air Medical is not allowed to transmit images during transport for the FCC.
I thought this was FAA.
He's got FCC out.
Okay, well, Air Medical, and I was kind of aware of this. Air Medical was the ones who first tried to do this. And Air Medical, if the FAA has very strict criteria about what you can transmit from an aircraft for various reasons. FCC, for one, because it's a cell tower thing, and the FAA is very concerned about signals which can interfere with navigational equipment. So yeah, that's going to be hard to do. I'm not saying I have the answers for it. I'm just saying what I can do to get it. I would never say what I can do to get around the medical board because that's not what I do. I want to cooperate closely and collaborate with the medical board so we can improve the care offered to the patients of North Carolina. So I don't believe that the medical board would necessarily agree with anything outside those parameters at this time. And, I think we want to maintain a healthy working relationship going forward with them regarding that. Is that okay, Tom? We practice that. Can you hold this real quick, Rob? One second, I got to repin here. All right, Dad. Dr. Alston, I'll refer to him as Dad, so just so you know.
He's being called the old guy.
Anyway. So I probably should have Tom and David Ezel talk about this because Tom put a huge amount of work going through the rules and regulations of all 50 states to figure out how they regulate their scope of practice. Do you want to say a few words about this, Tom?
So when this whole scope of practice issue kind of came up, and one of the questions that we've been talking about is, we're currently governed by the North Carolina Medical Board. What do other states do? So we reached out to NCAEMSA, had them help us do some legwork, got a decent response from 10 or 12 states. Then what we did was looked at the other states that did not respond, done a lot of research on their websites, looked at their laws, made some contacts with some people to try to find out how do other states govern their EMS scope of practice. This is the results of that. We just kind of put it on a graph where we could see we're one of 5 states in the country that are governed by their respective medical board. You can see that the bulk of those physicians are EMS physician medical control committees that is set up. There's 24 states in the country that do that through some shape, form, or fashion. A lot of it is subcommittees of advisory boards that's made up of EMS medical directors with some outside representation. A couple of states even had representation from the state medical board. However, the scope of practice was not directly dictated by that state medical board. So he just put that up there as a graph to kind of show the work that we had done to try to figure out where we lied in consideration with other states. So it was just a graph that we wanted to kind of show when we kind of answered the question of how is EMS medical scope of practice covered in other areas? Yeah. That's correct. We currently, it would require a change in general statute. It wouldn't be a change in administrative code. It would be a change in general statute. The ironic part about it, that when we got to investigating this and looking into it, is the fact that the Medical Practice Act, which governs the North Carolina Medical Board, and it dictates all the things that is governed by the North Carolina Medical Board. EMS is not listed. And that's kind of ironic that EMS is not listed, but they're who governs. And as you've heard Chuck say in the past, for those of us old timers in here, I remember when we were governed by the North Carolina Board of Medical Examiners. And as you can see, there's still 2 states that's governed by their respective Board of Medical Examiners. So one of Chuck's good analogies is we have moved from dead people to live people. So now we just got to figure out, do we stay with the North Carolina Medical Board moving forward in the future? Or do we seek other areas to get our EMS scope of practice? It is a challenge with the North Carolina Medical Board. A lot of it simply the fact, nothing wrong with their board. We have a very good relationship with the board, but there's no EMS representation on the board. And since they govern all these other practices, they're not going to put a paramedic on that board, nor are they going to put an EMS physician unless he governs all these other different areas. So it's just a challenge that we've been facing. That's why you hear Trip tiptoeing through the tulips there a little bit when he's kind of dancing around some of those issues. It's not that we don't want to expand the medical scope of practice. It's just because sometimes it gets very difficult and very challenging. I'll throw out an example that just to kind of reiterate that when he talked about the antipsychotics as a class, that makes all the sense in the world is having an antipsychotics as a class approved by the medical board for EMS scope of practice. Because if you go for a medication and then there's a medication shortage, what happens? We now got to go back and ask for this other medication. Let's just start going to the medical board and asking for classes of medications. That way we can deal with medication shortages. When we went to the medical board about the antipsychotics, they wanted us to go to a psychiatrist and a cardiologist to get a letter of approval, so to speak.
I think it was their entire interest organization. I mean, not like the society, not just a person.
Okay, so we had to go to these 2 groups and get permission from them to bring back to the medical board for them to even consider adding antipsychotics as a class. Just a lot of hoops to jump through that seem somewhat unnecessary, because if we go to some of those different societies, they don't know anything about EMS either, except for how to spell it. And so it is an ongoing challenge. We're trying to figure out how to work through it. And that's what kind of prompted us to work on this map. So probably far more than you needed to know.
No, that's great. Plus, I trust you to explain that much better than me, or maybe say it in a better way.
You can't say it because they govern your license too. I can say it.
Yeah, I've definitely thought a few times when I was talking to them, I was like, do I really want to say that? Because if something happens, I might have a problem. So let me get clipped up here. It's hard to,
Somebody said they really enjoyed the COVID vaccine for it.
oh, thank you. I appreciate it.
Reviews are coming in.
Well, thank you. I appreciate that. Do they have any questions?
No, that was just a comment.
Okay. So ketamine data. Just so you know, the regional specialists have worked really hard on collecting this data, keeping me in line, making sure we keep reviewing it. And part of the conditions for the medical board approving this is that we keep monitoring our own data. And they're allowing us to review this ourselves. So third quarter 2020 through third quarter 2021, it was given 1,202 times, 778 times for pain and 424 sedation. Please don't add those up because I didn't check to make sure they added up to 1,202. I know someone's going to do that and share that to me, but I think it adds up right. There were no cardiac arrests. That was one of the hard endpoints. So we didn't kill anybody. So I always feel really good about that. I know when I go to work, I always say a little prayer to myself, says, please don't let me kill anybody, and please don't let the residents or medical students kill anybody. So I always take that as a plus. So there were, out of the 424 cases for sedation, 3 patients needed intratracheal intubation, all in the emergency department. None of the 778 patients who got it for pain needed an airway, which is good. So there's 3 cases. They're all basically the same. Diaphoretic combative, hot skin, tachycardic. There was an initial drop in SATs. They got, 400 milligrams of ketamine. They were very unresponsive, not doing anything, and their respiratory rate wasn't doing as good when they got to the emergency department. I think it was probably an appropriate intubation by the emergency department staff. They got intubated. They did fine afterwards. Number 2, like an excited delirium thing again, cocaine use, elevated temperature, rolling around, yelling, combative, ketamine 400 milligrams. SATs immediately dropped to 84% on 6 liters and then 86% on non-air breather. I kind of wonder, maybe Roy can chime in here, if this wasn't one of those cases where the patient was so jacked up on cocaine and other things, and that the ketamine kind of took away some of the drive and sedated them, so the drugs, the cocaine and stuff was no longer working. That caused them to kind of stop breathing. That might have been what happened here. I think the intubation was probably appropriate in the ED. I think the care was appropriate also. The last one, only takeaway point from this one is, if you think you're going to sedate your patient, don't feed them first. So the crew did a really good job. They spent 20 minutes trying to de-escalate this patient who had autism. First time I'd ever seen this patient. And sometimes with autism, folks can have a little bit different reaction at times to medications than others. I actually went over this case with 2 of my emergency department pharmacists who also take care of a lot of kids with autism. They see no reason not to give a child with autism ketamine. So they didn't see any problems at all with this. I didn't either. But the patient did aspirate after the ketamine very quickly. I don't think it was because they ate, the chart actually stated they only took 1 bite of the cookie. So, but in general, it's probably better not to feed your patients right before you give them ketamine. But they got intubated, they did fine. They might have aspirated, but it didn't look like there was any major complications with their hospitalizations. So that's it. Any questions? Justin, any questions?